discussion again about concrete the real patients. So, Algirdas, how are you?
Thank you, Brian. So a lot of information, huge discussion. So thank you all. We have no time, so we must move forward to the next part. It's a multidisciplinary team discussion. Radiologist and with the urologist and we want to start from the first case report. Can we start? Or we need a little bit break. So we can start, I think, yes, with the first presentation. Dr. Augustinas Matulevičius, Vilnius University Hospital, Santariškių Klinikos. Please, Augustinas.
Hello, everybody. Do you hear me? Do you see me?
Good.
Thank you for inviting me to this event. I'm very glad to be here, and I'm very glad to share our experience, how we perform in the prostate biopsy in our Santaros Klinikos urology department. And today I have prepared for you one clinical cases from our experience. And during this presentation, we will have possibilities to discuss about this case. So I will present to you 67 years old male, and for this patient, because of elevated PSA, in 2017 was performed a systematic prostate biopsy, and the patient was diagnosed with low-risk prostate cancer. It was one core of Gleason 6, up to 40%. And this patient has been active surveillance since now. And after repeating a systematic biopsy, the prostate biopsy in 2020, only one column of the biopsy was found a prostate tumor. I will show you the protocol of histopathology, and the PSA level at that time was 9. The PSA density is 0.17, is quite big. During the particular rectal examination, nothing special we found. Some urinary dysfunction this patient has. It was nocturia 1-2 times per night, and that's it. So, as I mentioned, for this patient, the systematic prostate biopsy was performed in 2020, and we get the answer that it's also good differentiation prostate cancer with lesions 3+3, up to 4% of the core. And for this patient was suggested also to be in under active surveillance. But from 2020 to this year, the PSA level starts rising, and for this reason, the multiparametric MRI was performed for this patient, and we have diagnosis that it's benign prostate hyperplasia, and in the middle part of the prostate, in between the transitional zone and fibromuscular zone, we found the suspicious area is 8 millimeters size hypointensive node, and we have some increased diffusion restriction. It remains could be the Pirates free. Also, I think that our radiologist could make some comments about this lesion. Maybe do you see this slides before our discussion?
Yeah, we see the lesion is seen on T2.
Yes, it's because it's in transition zone, as it looks like. we should look on coronal images or sagittal images to look if it's an adenomatous node or if it's another kind of a lesion from these images that are depicted here. So it seems suspicious, but I'm not sure about the capsula, which cannot be evaluated properly only from axial images. So if it's not encapsulated nodule, I should say that it's 4, not 3.
Okay, so we in our hospital we have also the MDT team, and we're discussing every time before the prostate biopsy, and our MDT consists of a urologist, radiologist, and every time we're discussing. And in this case, we decide to write the pirates free, no suspicious of prostate extension from the capsule. But yes, at this time we have 2 lesions. One lesion was marked as pirates free in the fibromuscular zone, and one suspicious area was the transitional zone of the right prostate lobe. So, and I have a question, because every time we're discussing what kind of prostate biopsy to perform for this patient, because it's not a naive patient, it's a secondary patient. So I think that, what do you think? What kind of prostate biopsy we should to perform for this patient?
I think about only targeted biopsy. Yeah,
Yes.
because we have cancer, some 3+3, lesion 3+3 in the right side. Yes.
Yes.
So we see some suspicious lesion on fibromuscular zone. So targeted biopsy, it's not so easy. The prostate is quite big, so it's not so easy to reach it transrectally. So, but still, it's very small lesion. 8 millimeters. It's quite small. But I would think about targeted biopsy. Fusion biopsy is okay. We can do that.
Yes. Okay.
Or biopsy could be difficult to do in this. What do you think, Arturas?
Okay, thank you for your comment.
Of course, if we talk only about targeted biopsy, targeted so with special devices, not cognitive fusion. It must be or fusion or in bore. What choose better? In my opinion, this case is for in bore biopsy only. It's small lesion, like say, it's really small, 8 millimeters. It's small. It's anterior part in big prostate. My opinion, it's maybe, of course, I don't have experience with fusion biopsy, but what if we're talking about in bore biopsy? It's candidate for it's typical patient, typical lesion for biopsy in bore.
Okay, thank you very much for your comments. So I will show you results, and yes, we decide to perform the targeted prostate biopsy by MRI ultrasound fusion BK system, and we perform in general anesthesia in the lithotomy position, and it was the transperineal approach, and we perform this biopsy. Our radiologist contour the prostate lobe and the suspicious area, and for this patient, I have made the biopsy. It was the transperineal approach. I took course from fibromuscular zones, and also I took some samples from the transitional zones after our discussion. So, and we get the answer from first lesion in the from the fibromuscular zone. We get an answer that this patient has the Gleason 4+3. It was in all 4 cores from the lesion, and from another lesion in the transitional zone, it was the benign prostatic hyperplasia, just normal prostate tissue. Yes, it's quite difficult sometimes to reach this area because we have the pubic bone could give some problems to reach this area. At which time we have good possibilities to reach this area. So we performed this biopsy and got the high-grade prostate cancer. So, and the next step, we should offer some treatment for this patient. And I would like to ask you, what's your opinion? What could we offer it for this patient?
Once again,
I
how
think
old the patient?
67 years old.
67. Yeah, it's
So
quite
any
young
major
patient.
comorbidities?
No, no, just
comorbid.
the localized prostate cancer.
And of course, we need to discuss with the patient his wishes and to suggest him active treatment possibilities and to discuss basically the wishes of the patient. Maybe operation, one of these. But Dr. Chakauskas, I see, is on the line. What do you think about surgery?
So, colleagues, I apologize for connecting a little bit later because of some technical issues which arise. However, of the lesions are quite nice. Which plan this treatment. If you would like to think about neurovascular bundle sparing, so in this location, I think we can actually offer the patient nerve sparing laparoscopic prostatectomy, which would be, I think, quite nice. Nicely performed in this patient. So that would be one of the options. And I think even the patient could be even of the older age. He could also maybe could be offered the nerve sparing because as we know, it helps with the continence rate afterwards. So I think that would be an option. However, you see the 4+3, so it's a higher risk patient. So we talked about the systemic, omitting the systemic biopsy in this case. So what could give us better information if we are planning the surgery? And the first biopsy was quite a long time ago. So we don't know exactly what is happening around this tumor. And if we want to have a sparing, that could be also one of the advantages of having the systemic biopsy. But as we know from the previous biopsy, that was no active, aggressive disease there. So probably this is the good option in this case.
Can I ask one question for Dr. Albertas?
Yeah.
What information give you situation around lesion? For example, found some insignificant cancer or maybe next feature of significant cancer if we have diagnosis 3+4 and you are planned to radical treatment. What's necessary to information around lesion?
Thank you for the question. In general, I actually like to have a mapping because we really know that if we have 3+3 disease, quite many times we may have even, I don't know, PIRATS2 lesion or no lesion present. And if we have, for example, in the medial parts, in the posterior lateral parts, we have 3+3, for example, I don't know, 80%, 60%. And we have it bilateral. So we have a better idea of the amount of the disease. And I would be a little bit more cautious if I want to make a nerve sparing procedure in this case. If we are having in mind, like in this case, the previous systemic biopsy, which was more or less negative, and now we have target biopsy, which is quite precisely from the targets, and it's quite bad, so to say, bad prognostic disease. Yes. So in this case, I would say yes, I'm feeling quite okay with the sparing. But if we will have a systemic biopsy and we see that the disease is actually advanced also in the peripheral part, 3+3, 60%, 50% bilaterally, then I would be a bit more cautious about sparing.
Thank you.
So thank you very much for your comments.
Thank you, Augustinus. So we can move forward, yes, for the next case. So please, Barbara, come here. Second presentation.
Case report. So patient, 79 years of age, with the PSA dynamics from 2020, with the PSA increasing from 5.4 nanograms per milliliter to 9.5 nanograms per milliliter. Patient has an IPSS score of 6, prostate volume of 30 milliliters, and ECOG of 1. What we found on the MPMRI in November 2021, so Pirates 4 lesion in the base of the left lobe, and Pirates 5 lesion in transitional and peripheral zones of the right lobe. MRI fusion biopsy was done, and what we found was three biopsies were taken from each of the lesions. Adenocarcinoma Gleason 7 4+3 was found in all 6 of the samples with 12 millimeter length.
So can we see the MRI views? Maybe radiologists can show us. Okay.
Dark, the flow ADC value. Less ADC is in this part, but there's enough big focus, more than 15. It's about 16 millimeters, so it's Pirates 5. And in the left lobe, we see very little focus here. The flow ADC on to-do is, it's seen, but it's not very suspicious on T2. We know it, and we can find according to ADC value, which is very low here.
So one biopsy was done according to T2, and the other it was in-bore biopsy, targeted biopsy, because the lesions were very small. So we decided to do it in-bore, not fusion biopsy, and we succeeded to find the significant cancer in both lesions. Okay, Barbara, let's go further.
So I would just like to continue with the discussion, and I have a few questions, well, 2 questions. First of all, were systemic biopsies indicated in this patient?
May I say a few words about the systemic biopsy? Do we still question very much the systemic biopsy plus target biopsy? We still have EU recommendations maybe for the first biopsy to have anyway the systemic biopsy. So do we still discuss a lot about this, but should we omit this in all the patients? Maybe radiologist has the comment. And
I could comment. I think it's not added value for systemic biopsy. It's not added value for clinical information or some changing next steps for treatment this biopsy. We have enough information to what to do now. Yes, it's changing our opinion what to do next.
But we can miss the cancer in general, 15%. Maybe not clinically significant one. Yeah.
We found the significant cancer in the targeted biopsies. So I think we should ask not firstly about the systemic biopsies, but maybe about the treatment options for that patient at first, and then to decide if we really need that systemic biopsy for this patient for decision. Yeah.
Yeah, for decision, I would say that we don't need the systemic biopsy as well, of course.
Treatment options? Would we continue?
What about the ECOG-1? What do you mean by ECOG-1? Are there any specific clinical conditions that the patient is not ECOG-0?
Needed help from his family to move around the house.
Because? Did he have any clinical conditions or?
No, he didn't have any clinical conditions. He was more of a weakness, so he had a person living with him, his family member.
So the lesion is more apical lesion. So also radiotherapy is quite maybe an option in this case. What the other colleagues are thinking?
We might think that the patient is 79 years old. Yes, so COG-1. So there is risks for the surgery, I think, and we need to discuss about other options of active treatment. It might be ones of that radiation therapy.
But we can also think about no treatment in this case. Yes, the patient.
Yes, and to follow the patient, active follow patient. It's one of the my decisions, and then in case the PCA is growing, so then start to active decision to the active treatment.
But maybe the PSA is not the shouldn't be the cause of the initiating the treatment. So not necessarily if we have 15, 14 PSA, that would be not the indication for the treatment initiative. We see the frailness of the patient. We have probably no symptoms. He has TPSS of 6, as I understand. He urinates quite well, I believe. So there are not so many symptoms. And just I'm a little bit not sure about his comorbidities, because if he's not walking well, he's not so strong. So I believe that there should be some comorbidities, and we can have an idea about his life expectancy and so on. So unless he is symptomatic, that could be one option that maybe we can wait and see and decide about the treatment later. So other colleagues?
We need to understand how long he lives or with the cancer, or he will die from the comorbidities or from the prostate cancer. So we need to discuss, I think, this way. So 79 COG-1. Of course, we need to discuss with the patient his acceptation, and then with this maybe with his family, neighbors.
Yes, but we have to be always very objective. We have to know more about the patient, not only ECOG scale, but also all the comorbidities, the heart disease problems, and so on. So if we have more information, so then we can put it into specific counting. We can count. We can use the prognostic values for that. So I think we need a little bit more information to make this kind of choice of treatment, I would say.
And one more point about radiology: when the looking images, anterior lesion is enough big, it have broad contact with capsule, and we know it's aggressive cancer for +3. So I think I would like check maybe possibility of extracapsular invasion, maybe microinvasion, but it's point to choose treatment option 2. I think I keep in mind this moment too. It's possibility of extracapsular extension in anterior part with fast lesion, this bigger lesion.
T3 stage, so that could be also.
Yes, possible. T3 is possible. Yes.
Yes.
That's all with this case. Any wants to say? So I think we can move forward, yes, with the next one. Third presentation, case report.
So a patient of 73 years with BPH. So he has a family history of prostate cancer. His father died of this disease. Patient arrived with initial PSA of 4.7 nanograms per milliliter. It increased to 6 nanograms per milliliter, ECOG 0. On digital rectal examination, no palpable nodes were found. So clinical stage CT2. Transrectal prostate biopsies were performed twice. No cancer cells were found. Later, multiparametric MRI was performed. A lesion in traditional in traditional zone of the left lobe was found of Pirates 4.
Can we see the views? Because
Screen. Is that patient or not?
Yes.
No? One moment, we will show. So it's very small lesion
The left peripheral zone.
Yeah. Yeah.
in the apex.
Quantity is enough unclear. You can see very difficult here. And contrast enhancement.
Yeah, it's clearly visible on ADC.
On ADC, yes.
Yeah, and DVI images. The position is near the urethra, in close vicinity of urethra, and it's a lot of images on dynamic contrast enhancement, but still.
So the focus is on the apex.
This one. So we what we have decided. Barbara, say, can you say us what we've done?
So MRI guided in-bore biopsy was performed, and adenocarcinoma Gleason 7 4+3 was found in all three cores. And I have a few questions. After all.
So, yeah.
So the first one question for the radiologist.
Yeah, nothing. We can see only one lesion that is really suspicious for cancer, for clinically significant cancer. We did the biopsy. We get that quite aggressive tumor, 4+3. Is there any comments from pathologist?
No, looks like tumor is similar to previous one, and then just with a huge amount of Gleason 4 pattern and lesser amount of Gleason 3 patterns. So Gleason's grade group 3 in the higher extent. So I don't know. It's quite simple tumor at pathological ground.
Mm-hmm. So, and when the previous biopsy was done for that patient, the systematic biopsy I know was done, so that's why we did only targeted biopsy. Barbara, can you show the first slide? 73-year-old. Twice, no cancer. So actually, we can miss that cancer in the apex. So I'm not sure about I think we do not need the systematic biopsy because we have really aggressive cancer in the apex. So now we should decide what treatment could we offer for that patient.
Do we have any more information about his obstruction? Does he have any urination symptoms, BPH symptoms? How much and how are they?
Sexual function, of course.
As well, yeah, 73, yeah, why not?
If I'm not mistaken, so the IPSS score was 8, so patient did not have any serious problems, urinary problems, and erectile function was 15.
Well, in general, the problem is with the surgery and with the apical lesions as well. In all cases, when we have the positive margins, probably this is the place where we have to be the most cautious. So in this case, I would say that could be a complicated case to be with a negative margin. If we decide to go with the surgical treatment, he should be well informed that could be not the definite treatment, and we will have to have the radiotherapy as a backup or as a backup for the biochemical recurrence as well, or the positive margin. So that could be offered, but in very well informed patient. Or if he is having not so much lust symptoms, so then we can offer maybe the radiotherapy is one of types of radiotherapy, and we can discuss it about it as well.
With the patient.
Because on these images we can see that the volume of the prostate is quite big.
Yeah, and intravesical lobe is quite pronounced, I would say. Yeah. It's unfortunate we don't have the radiotherapist today. That would be quite of a help.
We're looking for one.
What about Dr. Žalimas? What does he think?
Searching for the radiotherapist.
What do you think? Would it be any of help if we would do the pathology during the surgery? or the frozen section, for example. What is maybe the Dr. Darius could tell his view on the intraoperative radical prostatectomy frozen section place?
Yeah, I think we perform the frozen sections and on our organs, so it could be possible. Yes, of course. We don't have very much experience with that, but I think we can manage it.
Because the centers, in some centers, they are doing as a routine, but as a part of the clinical trials usually. But the idea is that the surgeon usually marks the specific areas, so the base, the apex, also the lateral sides of the posterior neurovascular bundle sides, and usually it is important maybe in the apical lesions, because we usually have we have to discuss whether to cut more or to make the patient incontinent a little bit more or make it more radical. And another place is when we decide, for example, in some centers and very top centers, maybe they would try to do the nerve preserving in this case. I might say that they might, for example, on one side. So they will put, they will ask the pathologist to tell them about the positive margin in the apical region and the neurovascular bundle. And if it's positive, they will remove the neurovascular bundle. So maybe that would be the way to choose if we need the radiotherapy or surgery. And we choose surgery, we wouldn't need to have this option, I would say.
So now we have a radiotherapist with us. So I would like to show again the first slide. Maybe we can discuss a little bit more about radiotherapy treatment. So hello again. A patient of 73 years old with one lesion of Gleason 7/4+3 in all 6 cores of one lesion in transitional zone. We were discussing operative possibilities, and also we would like to ask a little bit the radiotherapist for his opinion. Maybe we can ask the images again.
Yes, please, because I can't understand really the question for me. Sorry.
So only these T2, and the question is about the possibilities of radiotherapy for the small lesion in the apex of the left lobe. That is not here. Up. It's
Yeah, on the apex.
On the apex. And not very big. It's about 6 millimeters.
So, if I understood well the question, so there are no contraindications for any type of radiation therapy. I mean, for external beam radiation therapy or for brachytherapy, this patient is suitable for both of them, but due to Gleason 4+3, so it's again, it could be external radiation therapy or combining external with brachytherapy, what we started to do now more widely, and I think it's much better possibility for patients for less surveillance.
May I ask maybe the question as a surgeon, what would be your approach, or maybe from your experience with the apical lesions? Would you go for right away for the radiotherapy, external beam, or would you combine it with the radical prostatectomy with the adjuvant radiotherapy for the apical lesions?
No, as I said, the topics of the lesion is not deciding for radiation therapy. So it's again, if it's not very fat person or obese person, how to say, and the external radiation therapy could do this. And as I said again, I will repeat, brachytherapy where I can reach it with needles too. So for us, I'm saying that it's optional treatment which we can use it. We have not so many contraindications, how to say, volume of prostate. Yes, it's contraindication, but the location of the lesion is not so much.
In the guidelines, this is one of the apical lesions for the surgery should be discussed quite a lot. So I think that's the point we should stress when you choose the surgical treatment or not. Yeah.
We're always discussing all the possibilities, but yes, if we see that we can do so, we can do so. As I said, I think we can do in this case radiation therapy.
Okay.
So the decision is radiation therapy for that patient.
One of the solutions.
Mm-hmm.
So we can proceed further with next patient, or some questions left?
There's one question left. As the patient has a family history, his father died of prostate cancer, would you send him to geneticist for further
I would like
testing?
to ask you about the genetic test. What do you mean about the genetic test? What type of genetic test is for the treatment or for its diagnosis? Because we do not have a pathological answer after radical prostatectomy, for example. Because I think that the decision of the treatment it's the same.
No. So you would not.
Maybe
What type
just
of
want his son
genetic
to do the
test?
test.
Yes.
Sorry, I didn't hear it.
What type of genetic test do you suggest for this patient?
So one of the first presentation here today was about the genetic testing and the alleles that are changed. So it's just a question: would you send for the further investigation, for the further maybe clinical trials, or do you have this facility? Because I think they do it in Santaros clinics. At least they mentioned it in the morning session.
I think the question is if we really need some genetic testing for that patient. So I think in this stage, when we have only cancer detected, and it doesn't change any treatment options, we can miss that. But still, maybe for the future, maybe patient has some relatives, some sons, and so on.
Yeah, for patient's sake, as you said, Mantas, perhaps it's possible to do. It doesn't change any strategy of treatment, but for patients' sake, yeah, it's possible.
And we agree as well, as you said, that we have a possibility, but we don't have. We need to do the test in order to make some decision. So in general, we in clinical practice at this moment probably we would not have much. But for the family history, yes, that could be advised. But in the future, when we need to choose maybe from some new agents, maybe from some new anti-hormonal agents and anti-androgens, maybe then we can think about it. Yes.
Okay. Thank you very much.
So we can move forward. Yes. The last one. presentation, case report today.
So last one for today is a patient of 68 years with a prostate volume of 45 milliliters. A patient had a PSA level of 1.4 nanograms per milliliter in 2014. In 2021, PSA increased to 5.06 nanograms per milliliter. On digital rectal examination, there was no palpable nodes found. A little bit about the past medical history. 15 years ago, patient was operated for colon cancer. He had the bilateral inguinal hernias. Left one was hernioplasty was performed using a mesh. The right hernia was left. It's mobile, not incarcerated, so he was not treated yet. So multiparametric MRI in 2020 showed a PIRATS 3 lesion in right transitional zone and PIRATS 4 lesion in the left transitional zone. In 2001, MRI was repeated. Again, PIRATS 4 lesion in right and left nodes. So MRI-guided in-bore biopsy was performed. Gleason 6 and Gleason 7, 3+4 were found in all 6 of the biopsy cores.
So can we see these lesions? Can we show us?
Radiologist screen, yes.
So we see a focus in the transition zone, left, right lobe, whereas some capsule we can see, but when we see on the coronal view, there is unclear contours in the focus, and we have very low EDC value here. And the other focus is on the left lobe, peripheral zone here. On T2, it's here. So this focus are PIRATS 4.
And which focus, which lesion was 3+3 and which was 3+4? Barbara, can you remember?
Can I? So, the on the right lobe there was a 3+3 Gleason 6 core, and on the left zone it was Gleason 7.
So actually we have one lesion in transitional zone and one in the peripheral zone, and in peripheral zone in the left lobe it's more aggressive. Okay, thank you. Let's go further for the discussion.
So again, the same question, where systemic biopsies were indicated in this patient.
Maybe I have a question to the question for the radiologist also who was performing the biopsy. Are we really 100% sure that we are actually really have a good well targeted this lesion? Because we have from the bigger lesion, which is looks quite scary in the radiologist view, we have just 3+3, and from the small lesion we have 3+4. Clinically, they are not so well correlate. So, what is your opinion?
Yeah, so we did it in in-bore biopsy because when tumor is very small and we decided to find the tumor there. Can you show my screen, please? So we did the biopsy from exactly from the tumor. So, and that was from that small tumor, the biopsy done, and the other was from bigger tumor. Yes, from the transitional zone. So actually, we had a free course from each lesion. So I guess that it's really the Gleason score is what we have from the most aggressive parts of the tumor.
Well, if you talk about the threshold, for example, you say that the small lesion, you choose the in-bore biopsy and not fusion biopsy. So what would be the threshold or the location, or how do you choose? Or it's just more the jazzy way of choosing, or do you have some specific threshold when you decide?
If the tumor is less than 1 centimeter, so we prefer to do in-bore biopsy. And after that, we can decide if we need, according to the findings, if we really need a systematic biopsy for that patient, and we can do it. Either blind biopsy or some targeted mapping biopsy. I think mapping biopsy is needed only when you are suggesting for the patient some focal treatment in a trial, participating in some trials. So then the mapping biopsy is really needed. In this case, I'm not sure about that. I think it depends on the decisions we will do now about the treatment. If we really need some systemic biopsy or not.
But in general, do you think that if you would like to perform it in two consequential procedures? So because you've done one biopsy, why not to do the systemic biopsy at the same time? But from the surgical point of view, that helps actually. We don't have the good tools now to predict the involvement of the lymph nodes. For example, Briganti nomograms or some other tools which are not really still, we are not still equipped with the right tools to decide whether to do the lymphadenectomy, the involvement of lymph nodes, and so on. So I think we are now in the time of change, and we have new diagnostic tools, but we still don't know how exactly to apply them for the clinical decisions. So that one of which we need to do, whether to remove the lymph nodes or not. So that would be one of the decisions, and how bad is this disease, for example? How the risk of this disease as well? So we don't have the bigger picture. So maybe we are right doing this just from the targeted biopsy and doing the decision, but still we don't have enough experience to tell this for sure. That's probably my view.
Yeah, it's always difficult to make decisions from less material than from more material. Of course, that's why we do the systematic biopsy. But this systematic biopsy, they have their complications. There some problems. There are some with systematic biopsies also. So that's why we need, for example, in this case, I think we would miss both lesions with rectal ultrasound guided biopsies because of the position of one lesion and the size of the other lesion. So that's why at first we need cancer. So if we won't get cancer from these lesions, then we again should decide what should we do. Usually, if I would didn't find the cancer in this case, I think we need this patient to be on active surveillance or on follow up at all, because we don't have cancer. But in this case, we get the cancer, and now we have to decide what to do to that patient, if we really need that systematic biopsy or not. Just to make some staging and so on. So these are the questions, they arise always for each patient. So all these patients are different. Despite the fact that the lesion was the same like previous lesion according to pathologists. Yeah, but still the position, the size, and many other factors, they influence on the decision making.
What, if I may add, actually, we are discussing the wrong question in general. I think that in general practice all over the world, there is not so much thinking when you do the targeted biopsy whether to do an extra systemic biopsy. Probably it's never done. So honestly, so if you are not sure that you targeted well, so then maybe you do the mapping. But if you have a, as you say, the significant cancer, you have the result of targeted biopsy, you're done. You're okay. You have to make a choice, the clinical choice. But if you the question is, do we have enough information, and why not to have a little bit more? So I think that this is the main question, whether to perform the systemic biopsy together with the targeted biopsy in order to have more information. But probably if you have the clinically significant cancer, you will never probably perform the systemic biopsy unless you need to have more information for the focal therapy, for some specific therapy, but which is actually not usually the case in regular clinical practice nowadays still.
Yes, you are absolutely right. So.
Okay.
Could I have some short comment on Dr. Salbert's question about the lesions representation? Little bit come back, and from pathologist point of view, it looks like I think that Dr. Mantas was pointed quite good, because on the right side it was bigger tumor, but from transitional zone, and from this part of prostate, tumors nearly not always, but in more cases are of Gleason 3+3. So I think it's good representation. And also on the right, on the left side, it's also smaller tumor, but still we have found the Gleason 4 pattern. So I think with representation of the tumor focuses, it's okay.
Small is not better, not always.
Yeah. I'm not questioning the systemic biopsies. I just commenting on.
No. I mean that the left focus is smaller, and it looks maybe not that bad, but in pathology it's worse. So. Okay.
So we can finish with this case and then the treatment options for this patient. And it suggests the patient had previous operations, hernias, so it's some kind of difficulties about when we're talking about surgery, about maybe laparoscopic surgery.
Yes, but I would say that the inguinal hernias and previous surgery shouldn't be the contraindications for the surgery. So as much as we have experience, it doesn't give much of a trouble. Maybe it adds up maybe 10 minutes of dissection and finding the case. I would get a little bit more information about the rectal surgery, what kind of a surgery was that, and as from the surgical point of view, you could also do the extraperitoneal surgery, which maybe helped us. But for the extraperitoneal, then the hernias make more problems. So I would gather a little bit more information about what surgery were performed before that. So maybe you have some more information, what kind of resection was made.
I cannot comment. Sorry. I'm sorry, but I cannot comment on this at this moment.
But he doesn't have any stomas.
No.
He's now end-to-end anastomosis. Okay.
We know the local MDT decision. It's radiotherapy. So
okay.
I think
so
it's,
you don't know
it's
how,
quite
how
good,
it would
good
have
decision
been from
for this
inside,
patient.
yeah?
Yes.
So if sorry, if you're asking about radiotherapy, so for me it's more complicated case than previous because sure we have to know what kind of surgery it was, but in any case, if it was rectum surgery, it would be more reactions, complications from any radiation oncology treatment. So it's more difficult to choose a dosimetry plan, more difficult to perform brachytherapy. So I am sure that the first choice for this patient should be a surgery. And if there are some doubts, we can talk about radiotherapy.
I would agree that always the difficult patients is also always difficult for many kind of treatments. So, but I would say that we could offer the surgical treatment, and usually it's not so as difficult as it sounds usually from unless you know some complications or you had some complications during the rectal surgery. Maybe it's in two. Maybe there were two surgeries made, the stoma and so we need to know a little bit more information. But in general, I would say that if the patient is not that obese, that would be one of the choices. Yeah.
So again, it's about radiation therapy. If we will know full history and which level it was operated. So again, it's not absolute contraindication for radiation therapy, but I mean that maybe in this case surgery is more favorable for the patient.
So we have question from virtual. So I try to understand in which case. So I just read and then we try to ask. Could you comment Andrew Wicker's notion that multiparametric MRI target biopsy artificially inflate the number cancer which are not actually CS? So
could you repeat the question, please?
Could you comment Andrew Wicker notion that multiparametric MRI target biopsy artificially inflate the number TS cancer which are not actually TS? So
it's significant cancer. I've never heard about that.
So I think it's
well. This is the actually probably not really not correct, but I mean if you do the target biopsy, actually it should reduce the number which is artificially inflated. So the target biopsy is actually, that's the reason of target biopsy, to reduce the number of non-significant cancers and to increase the number of significant cancers found, and it does not inflate anything if we find significant cancer. So I would not agree with this notion. So I'm not sure from the radiologist what is Dr. Shuvashovas maybe has the idea. This is more philosophical question.
Yeah, I think if we are looking for really clinically significant cancers, so the targeted biopsy could find that cancer in the prostate. And of course, we can miss clinically insignificant cancer. What is the idea of the targeted biopsy? Not to find the clinically insignificant cancer. So this inflation of I actually I can't imagine how can we make cancer if there is no cancer. it's a question. It's a rather strange question, because we are not looking, and we're not trying to make more cancers in the prostate. We just need to find the really clinically significant cancer.
But
It's
maybe this is not
percentually
even
different. Yes, in targeted biopsy we have less samples, but more cancers in samples. If looking from this point of view, but not absolutely. Of course, it's our goal of targeted biopsy to find more clinical significant cancer and differentiate and miss and don't get insignificant cancer. So
maybe there is the question in, if we take the biopsies from the lesion, for example, free course of the positive cancer, if we find the free course, so but it doesn't mean that there are free lesions of the cancer. It means that the lesion is one still.
Yes. But I would expand the question for the radiologist in general. So I think this is not the question of the biopsy, of the target biopsy, but this is more the question of the evaluation of the MRI and also the period score evaluation. So well, we would say that with the biopsy we target and we actually hit the target more or less, not 100%, but it's quite high. But the main idea, the decision making of whether to biopsy this target or not, and well, periods 3 lesions, where we do the main decision whether to biopsy. So we may do the inflation of this, well, actually of hyperdiagnosis only if we maybe evaluate these lesions maybe as a higher rate than the lower rate. What do you think?
Decision is not making only for one criteria. We are looking like now we have MDT and talking about decision what to do. The same decision with biopsy or not biopsy some lesion. And PIRATES 3 lesions are intermediate. We know 4, 5 recommended for biopsy. 3 is in our trainings are recommended high risk for high risk patient when we clinically suspicious lesion. It's a clinically suspicious significant cancer. So in my opinion, in my experience, I looking negative to biopsy PIRATES 3 lesion because we have many over diagnoses, because we are looking how to say who evaluate MRI, because when radiologist is not experienced, it's maybe doubtful in case, and this PIRATES 3 he don't have no cancer, but he afraid to say no cancer, but he not sure it's cancer. So it's think 3 is okay. It's not okay. Real PIRATES 3 is enough rare condition. If you're looking methodically, it's many cases are negative in our experience. How we do, I in my presentation later I have one slide about it. I am looking negative PIRATES 3 biopsy. We can follow up. We can this patient looking later. We have tools how don't miss cancer, but I think additional biopsies it's not good to do when it's necessary. Thank you.
As long as I know that PIRATES 3 is one of the percentage of PIRATES 3 in the center shows the how to say the experience of the center.
It's quality of center. Yes, it shows quality of center. Yes, and if it's more than 15%, it's not good.
Okay. So yeah, and as a urologist, we would like to better know, because we are the ones who actually making the choice whether to do the biopsy or not. And actually, we are making the choice from your decision. So actually, this is completely the joint decision. So as in our center, we have every biopsy is discussed with the radiologist at the special meeting. So I think you have the same in oncology centers, but in Santaros Clinicos we as well. Every biopsy is not any biopsy is not done without an MRI, and when you have an MRI, we have the joint discussion, and we have the clinical setting, we have all the MRI setting, and we decide what kind of biopsy, which approach, and whether to biopsy at all. So then I think that these people should work together in making the decision. So then you have the whole picture and not only one number. So I think this is the way to work, and because this decision makes all the story later. Because if you have a cancer, then the story begins. If you have clinically non-significant cancer, again you have a long story, which is actually annoying. So I think this is maybe this is the way, because now we have probably 95% of the patients are coming with the MRI before biopsy. 99 maybe, I would say.
Okay.
So that's all today, I think. Thank you for today's team, and we'll make a break, I think, and after 30 minutes we will discuss future questions. Thank you all.
Thank you very much.
Thank you very much.